Thank you for joining us this morning.
Good morning.
As Sally said in her email, Clifton has become a little bit of a media star. So we have to keep him humble as best we can. But I'm pleased that he's made time to be with us this morning. And many of you may know Clifton and his family. He is a native of Gainesville. So we are glad that he has chosen to come back to this community to practice. By skill and training, Clifton is a cardiothoracic surgeon. So if you need your chest cut open, he's your guy. But hopefully, that's not something that we'll see him under. Clifton has certainly another skill that I'm not sure you can train for, and that is one of leadership. And for the past 2+ years, Clifton has been chief of the medical staff of Northeast Georgia Medical Center. And Clifton, if you've noticed any of the names popping up, there are several former chiefs on this call, so I'm sure they can empathize a little bit with what you've been through. Clifton took on this role in the early fall of 2018, actually stepping into the role a few months earlier than he was supposed to, but he did. And I think I would be safe in saying that had he known what we would be facing, he might have run screaming from that challenge, because not very long after he assumed the role, of course, he had to deal with the fallout of the cardiologist leaving the medical community, and then obviously what we've had to deal with over the past year. But I will venture to say, and I think Latrell, as another member of the system board, will agree with me, that we are blessed that we had the right person in the right place at the right time. And we are grateful for that. So Clifton, it's yours, my friend.
Jackie, let me make one announcement first. Everybody that is unmuted, please mute your mic so there's no interruptions during the presentation. Thank you. Okay, sir.
Very good. I'm assuming y'all can hear me okay. So, well, first, thank you for your kind words, Jackie, and it's been a pleasure working with you and the board for many years here. I actually chose to be chief of staff during this time because I thought that the biggest challenge we were going to have was rolling out GME in July of 2019. That proved to not be a challenge much at all. It got overshadowed by a bunch of other things. So I am from Gainesville, Georgia. I'm very proud of that. The fact that I'm sitting here doing what I'm doing is due to many people who helped raise me and guide me and wrote letters of recommendations and such. John Darden was the first surgeon that allowed me to come in the operating room and see him do an appendectomy, I think on a Saturday, late Saturday evening one time in 1976, if I remember correctly, John. So, and that was a formative moment for me, knowing that I wanted to become a surgeon and always had dreamed of coming back to Gainesville. I won't go into all the details of where my career took me and what I did, but I can tell you without the teachers and coaches and influences of many of the physicians in Gainesville as I was growing up, and then more importantly, my parents and my sisters, and y'all probably know my youngest sister, Mary Lana, who's doing the preschool children's stuff at United Methodist Church now. So I'm very fortunate to have had all those formative influences to get to me to where I am. I'm not really sure exactly what y'all want me to talk about, so I'm going to talk for just a few minutes and then try to answer questions because there may be more benefit in that. But just kind of to explain our COVID journey, really since last February, we pulled together the first task force to start looking at COVID. It actually may have even been before that, but it was in February we were having meetings. To be honest, I was personally thinking, yeah, we'll do all this stuff because we have to prepare, but surely this is not going to be the worst case scenario that many people had said might happen. Unfortunately, I was very wrong, and this has been far worse than any of us ever anticipated or planned for. The system was smart enough to order extra PPE and extra equipment for negative pressure rooms, and we were able to expand and respond to that. But quickly, 6 months worth of PPE was gone in about 2 weeks, and we found ourselves in early April in pretty desperate straits trying to just get the equipment we needed to keep the nurses and doctors and techs and therapists safe and going in the rooms. I'm sure you're all familiar with the growth. We've really had 3 spikes, but I will tell you that the initial fear that was there as we started seeing the numbers exponentially go up in April has been replaced by fatigue now. There was a great fear as you saw the numbers go from mid-March, there were about 10 cases, to the end of March, there were about 60 cases. And by the middle of April, there were 130 cases. And by late April, there were 159. And we just didn't know when or if it was ever going to stop. And there was a very real fear that we were going to have more patients that needed care than we had the capacity or the resources to do for. We did do create a critical care triage plan, and we've always had triage plans for natural disasters and like tornadoes and hurricanes and explosions at a chicken plant and those type things. But this was a very different type of triage, and in that this triage was for when we have more patients than the resources can provide over several weeks, months. We're now 11 months into this. What do you do? Who gets a ventilator and who doesn't? And Jackie and some of the other folks that were involved in this saw that that was a very difficult transition and plan. Fortunately, we never had to implement anything close to that, largely because we were able to expand and grow the system to take care of that. We started off in March with 67 ICU beds in Gainesville and another 12 in Brazelton. We expanded pretty quickly to about 160 critical care and intermediate care beds. Unfortunately, we couldn't expand the number of nurses and critical care doctors, and we're fortunate to get a lot of help from the state to help us weather that storm. So we kind of got through that first phase. I remember thinking if we can just get to the middle of May, then we'll be okay. And things did improve until July, when they peaked again, and we I think had 179 or so patients then. And once again, the peak subsided somewhat. And then we were in the fall, in the middle of October, we only had about 60 patients. And by that time, we were about 5 or 6 months in, and there was a tremendous amount of fatigue and just a concern of when and if this is ever going to go away. We started seeing numbers go up in early November, and the fear of the holidays and the winter surge were real. We probably were, I think by middle of November, about 135 patients. And unfortunately, we sent out a lot of information saying, please don't have big family gatherings and such, because that is one area where we see a lot of spread. And unfortunately, over Thanksgiving, 2 weeks after that, the numbers continued to rise. We did a video, I think before Christmas, again, pleading not to gather and to do the social distancing and wear your masks and those things that we've been doing all along. And by Christmas, we were over 300 patients. We peaked around 360 the first week in January, and have been fortunate in that the numbers have started to decrease again. So what we see is typically a week to 2 weeks after an event or gathering, the numbers of patients with COVID go up, and then we start to see a week later the hospital admissions go up. And then currently our ICUs are totally full and will be probably for at least the next month, because it's about a 6-week period that we see patients start to either recover or pass away. We've seen recently an unprecedented number of deaths, averaging anywhere from 8 to 15 people per day, which is unheard of. In my cardiac surgery practice, I might have 2 deaths a year. And so to see that, it's been a tremendous load and wearing down the staff to unprecedented degrees. But they continue to carry on. So it's been a very difficult transition. I think the article that was in the AJC last week was a fairly good representation of just the way it is. You almost get numb after a while. but there's still hope, and that hope to me is in the form of the vaccine, and I hope many of you have had the opportunity to get that. The reality is, until we get enough people vaccinated who are somewhat immune, and then enough people who've had the disease, it's going to continue to have this spiking pattern every 2 or 3 months. We're going to continue to see surge after surge. The fears that we had of being overrun thus far have not occurred, but we've had significant expansions to the point to where we had a gym with 15 to 20 patients in it over at Laurelwood, which is the mental health facility right across the street. We've had multiple patients in the hallway. We've taken pre-op areas that normally we prepare patients for endoscopies and surgery, and those are rooms now. We took some of the post-op areas and 10 of those rooms and made ICUs out of it. And we're currently handling about 250 more patients than we were a year ago at this time. So tremendous amount of expansion, but been able to handle and take care of all the patients without having to turn anyone away. We have had situations where we have patients in other hospitals that need to be transferred here, and we just can't take them. So in some ways, that's limiting or rationing care to some degree, because we just don't have a place for them, and those patients in the mountains hospitals end up being cared for there as best they can. So again, the hope is the vaccine is going to be a significant benefit to us. I'm hopeful that we're going to get enough people taking it. Currently, we've got about half of the frontline and physicians, nurses and such that have taken the vaccine. We've got another 800 or so staff that have had COVID and recovered. We've had 2 nurses that did not recover. So there's, gradual acceptance and implementation of the vaccine, not only at the health system, but also throughout the community. I think we've been able to give vaccines to over 3,000 of our community members, and we're sharing vaccine with Longstreet Clinic and other primary care offices, so that hopefully more and more people are being vaccinated. So just as a comparison, though, when you look at the influenza A pandemic in 1918, there were, I think, some 500 million people that had the disease. Currently, we've gotten, I think with COVID, there's about 100 million patients with it. With the 1918 flu, that was somewhere around 50 million people died. Currently, we've had about 2 million deaths worldwide, and certainly in this country, we've had about 440,000 deaths. So this is a pandemic that none of us were alive in 1918, so it was something that none of us had ever experienced, but it's certainly been an experience to see and understand. I thought with our healthcare system being the best in the world, that we would be able to manage this better than the rest of the world. And in some ways we have, but in some ways we haven't. And I think, it's shown us that our public health efforts really need to be expanded, and we need to do a better job of taking the entire approach of medicine, as opposed to just taking care of people when they're sick. We need to be taking care of people throughout their lives, and expanding our roles in managing people's health care, instead of just trying to fix things when they're broken. So with that, I don't know what the format was going to be. I'd be happy to take questions or comment further on any of these things. So I'll just open it up at this point.
Clifton, you referenced, and a lot of people, of course, know, we've talked about this in our Sunday school class, the GME program. And I actually was in the hall of the hospital not long ago and ran into one of the second-year surgery students. And I mean, talk a little bit about the impact of them starting their career in situations like this.
Well, I'm sure that's certainly nothing that they anticipated, and it's certainly nothing we anticipated. It was, first off, I'm very proud of the fact that the health system is growing and creating the GME opportunities. when you looked at where the state was, the great majority of medical students in the state of Georgia had to go elsewhere because we had less than half of the GME opportunities for medical students in the state. So most people had to go elsewhere. And we also know that most people will end up practicing somewhere close to where they train, about 70%. So I think it's the right thing to do. We did find that when this started back in March and April, we pulled the residents out of their normal role and then put them in a 2 weeks on, 2 weeks off schedule, so that in case everybody got sick, at least half of them would not have been exposed the 2 previous weeks before. And we did that with some other staff. But within 6 weeks, they were back out doing the normal things throughout the hospital. So they've been very helpful. But we're still very early in the growth. We've probably got 60 residents now, and there's going to be probably 200 in 3 years from now. And we've got other programs that are come online in the emergency room and psychiatry and OB. So I think it's been the right thing to do. But for them to go through something like this, and the same is true for the new nurses, because we have a lot of nurse residents that come through the various different schools, and we probably have 120 to 150 nurses that are doing a 1-year residency, getting experience in multiple places in the hospital. This is not a normal experience, and they'll probably, I hope, never have an experience like this for the rest of their careers. But it has been certainly unique and different for all of them.
I got a question as well. What have you learned from this experience that you would do different when if COVID-23 shows up? Or something like that?
Yeah, I would think what I would hope we would have is a much stronger public health department and resources. We found early on that even though we have contact tracing and such, we've probably got 1/100th of what we really need to isolate people. When you look back at the previous viral outbreaks or pandemics, SARS and MERS, which were in the early 2000s, those were contained, and it was largely contained through the public health efforts. And our country, I think as a whole, has not invested in public health, and nor did we have the resources to implement that. In the early days, we were testing people and assuming they were positive, and it was 5 to 7 days before we could even get a test back, much less then go out and start doing contact tracing. The other thing is, when you look at one of the reasons why our community was impacted so profoundly compared to other communities in the state, I think a lot has to do with the socioeconomic situation that a lot of people, especially those who work in the poultry industry and some of the other manufacturing, when we tell people you've got COVID, you need to go home and isolate yourself, that's great advice. But you live in a home with 12 other people in 4 bedrooms or 3 bedrooms, you can't realistically isolate yourself. So we did not have the infrastructure to be able to isolate people and do the contact tracing. I think that's the way to deal with viral pandemics in the future. The other thing that's very helpful is the messenger RNA vaccines that have been developed are unique. We've never had messenger RNA vaccines before. The company Moderna was founded in 2010 with the expressed goal to create messenger RNA vaccines. The nice thing about them is they're a synthetic vaccine. They don't contain any part of the virus. They're a replica of the genetic portion in this particular one of the spike protein. And so we can very rapidly and safely make vaccines. And I think that this is going to show that this is going to be a safe and effective way to do that. The mutation of this particular virus is not as rapid as things like the flu, but it's certainly not as slow as things like measles. When you look at the measles vaccine, it's no different than it was 60, 70 years ago when it was developed, because measles has a very low incidence of mutation. The flu vaccine, we have to revise every 6 months because it mutates, and every year there's a different flu vaccine. COVID's somewhere in the middle of that. And but I do think with the rapidity that we can create and develop vaccines, even if the South African variant and the UK variant were to be significant, they seem to be currently affected favorably by the vaccine. But if a variant came that was not, I think within 2 or 3 months, we could have a booster that would be available that we could implement. So I think the changes in the vaccine creation and modification is going to be key. But I also still think that in strengthening our public health structure is going to be the key in the long run as to how we're going to be able to deal with these things. But those are the two things I would say. We've learned a lot about the immune modulators and the antibody creation. We can create synthetic antibodies. And so I would tell anyone who gets COVID now, certainly if you're over 65 or if you have increased risks, the synthetic antibodies that we've given probably 500 or so doses, and it's made a significant difference in preventing people from getting sick and having to be hospitalized. But you do need to get that early on in the process within the first 10 days of being diagnosed with COVID. So a lot of new treatments, vaccines, and public health, I think, are the things that will help us in the long run.
Hey, Clifton, could I ask a question?
Sure.
What do we say to the doubters and the naysayers about vaccines? I'm amazed sometimes at some pretty smart people who will say things to me like, well, I'm not getting the vaccine. Nobody in my family is getting it because it's got aluminum in it, and aluminum will give you Alzheimer's, or, all those kind. What's the best thing we can say to people who are reluctant to get the vaccine? Because in the long run, if they don't, it's not going to help us achieve our goal of the herd immunity, is it?
That's exactly right. Well, if you stop and look at the data, the scientific data, it's very clear that the vaccine is safe. Any medication is going to have potential for some side effects and such. There's some recent data regarding infertility and pregnancy because that was not tested, and that shows that the damaging effects of COVID is far worse than any potential side effect from the vaccine in that population. But the reality is, unless, for most people, unless you have a personal experience or some sort of personal interaction with people who've had this, it's sometimes hard to believe. And with some of the politics and some of the news that comes out there, I can see how and why some people may be confused about that. But I can tell you it's very real. I've seen just way too many people die from it, and the vaccine is the answer. But I will tell you, we've got about 50% of our nurses and doctors who've taken the vaccine so far. I can't explain why all of them aren't, but there's still, even in the medical community that see this day in and day out, there's not complete acceptance of that. And that's something that we're continuing to work on and go from there. But I've seen 30-year-olds die. I've seen 40-year-olds die, and I see people get very, very sick. And having had COVID myself, I can tell you that it's still, there are some short-term memory things that I feel like I'm experiencing still related to it. But fortunately, I was able to recover completely and been back at work for 3 months now. So it's real. And if they'll stop and put aside whatever prejudices or insights they have that might be clouding that and look at the true data, then there's really no doubt.
Clifton, if you've had COVID, how long is the immunity? Is there known how long the immunity is? And is this going to be something that you're going to have a booster shot once a year once you've been vaccinated? And how does all that work?
Well, we don't really know as far as the booster shots and such. I suspect that there probably will. And I think the companies that are making the current vaccines are anticipating that, but that's really not known yet. For people who've had COVID, there's good data to show that at least 8 months, you got to remember, this has only been around on a large scale basis, really for the past 10 months or so. So there seems to be good immunity from the antibody levels and your B cell and T cell responses and some of the other immune modulators that are active for most people at least 8 months. And we suspect it may be longer, but until we get there, we don't really know. But I suspect that next year, and again, if there are variants that we may need to adjust, then there may be the role for booster shots and such, much like the flu vaccine. I don't think it's going to be a yearly thing like flu is, but I do think that there will be probably the need for that.
So how long is the shot good for then? If that's okay, then is it like the measles shot? Once you get it, it's going to be good for lifetime, or?
Well, we don't know yet. For me, if it mutates like measles, then yes, it'll be good for that. If it mutates like the flu virus, it's going to be every year. So I suspect it's going to be somewhere in between, but they don't really know yet. But the antibody responses and the immune responses from the vaccine seem to be significantly higher than if you get the disease. When you have the disease, I think somewhat of the immune response depends on how severe your case is, and so people have varying levels of responses to that. But I would tell anyone, if you've had it, to go ahead and get the vaccine, because you do have significantly higher immune protection from that. And I suspect it will be for greater than a year, but I just don't think we know yet.
Clifton, this is John Darden here. First, let me say how proud we are of what y'all have done. And those of us who have been part of the medical community previously during the different phases, it just makes us so intensely proud of what y'all have been up against and done. And the community is so very, very appreciative of all the efforts. One thing I would like to ask, for those of us who have had it and others who will have it, do you think that the immunity that we have from this one also holds across and protects us from the mutations, or is that just something that we don't know yet and we'll have to wait and see?
Well, I think the data so far suggests that it does. So I think that now it doesn't protect you against all coronaviruses, but at least the novel coronaviruses that are similar to COVID-19, it appears that your immunity does protect you against at least the variants that have come out so far. We don't really know going forward, but so far, the fact that you've either had it or had the vaccine seems to be protective, at least in all the studies that they've done so far on that. But that's still an area, as things are going to mutate. Viruses always mutate. It just depends on how much they mutate and how the changes. The thing that's different about this particular vaccine is that it's looking at the spike protein, which is on the surface, and that's how the virus attaches to the body. And if you have, even with changes on that, even if the virus changed, as long as it has a spike protein, then your body would still be immunologically effective in fighting that. So kind of depends on where it mutates and such. But I think the general answer is I think we're all protected to a significant degree now, and probably will be going forward. The question is, how long is that immunity going to last? And again, there are a lot of people working on that. I feel sure that we're probably going to end up with boosters at some point, but whether it's a year or 2 years or when, nobody really knows yet. But I feel pretty comfortable we're protected.
Clifton, I have a question too. We both had COVID. Should we be checked in a few months? I've gotten an antibody check and I have positive antibodies. I mean, is there a benefit to in 6 months being checked again for antibodies?
And I don't know. I mean, I think that logically, I would say yes, if COVID is still prevalent. If we're able to vaccinate enough people and the numbers go down and it's not spreading in the community, then there's probably less of a need for that. But as you know, even if we do have protection from it, we can still get exposed and we might still harbor the ability to spread the virus. but again, more than likely, we're not going to get sick from it. We don't really know how much the vaccines and prior infections affect your ability to recatch and spread it without even knowing it. And so that's actually important data to know, which is why wearing a mask and continuing all the community public health measures is going to continue to be important. But I don't really know. If there's still COVID around, I think there's going to be some good recommendations are going to come out to tell you, yes, you probably should get checked, or no, you're protected, don't worry about it. But I don't think we know that yet.
And my other question has to do with our adult children. You know, a lot of us have children in the probably 45 to 55 age range. When do you foresee their being able to get vaccines?
Well, that's the $64 million question. Our ability to give vaccine is significantly greater than the number of vaccines we're getting. We asked back in early January for 50,000 doses for the health system because we were convinced we could distribute those within the month. Unfortunately, getting the vaccine has proven to be more difficult. The way they're doing it is based on your ability to give the vaccine and the number of cases where you are. There are all variables that the state and the national people are doing as through how they distribute it. And I think they're also finding out that while they were promised a lot more vaccine than they've been able to produce, they've actually not been able to produce it quite as fast as they thought they would in the beginning, but that apparently is picking up rapidly now. So if I had to guess, I would say that we're going to be in phase 1 probably for another 4 weeks. And I would think by the end of February, they'll go to phase 2, or I think it's 1B and C, where essential workers and those who are at high risk will be able to get access. But I would expect by late spring that the majority of the population would at least have an opportunity to get one if you're at high risk. But again, that's purely a guess. The other thing is there are other vaccines coming onto the market, the J&J vaccine, which is more of the way that we used to do vaccines. It's not a messenger RNA vaccine. It's not as effective, but yet it's a single dose. There may be a role for that, helping and expand that as well. But I just don't think anybody really knows. I'm disappointed we've not been able to get more vaccine because we clearly could distribute it. But I think time will tell as to that. I would still recommend anyone who can to get the vaccine, no matter what your situation is.
Could I interject something here? Can you hear me? Can
Yes.
you hear me? That's
Yes.
Jim Butt.
Hey, Jim.
Supposedly every cloud has a silver lining. It's hard to find the silver lining in this cloud of COVID, with one little exception, and that is that all other viral illnesses are way down as compared to past years. And the explanation is hard to come by, although there were an increased number of people receiving the flu shot this year as compared to previous years. But also when you have a virus like COVID, you release a lot of interferons and other cytokines, which may be beneficial in preventing the adenoviruses, rhinoviruses, et cetera. It's just probably the silver lining, if there is one, in this particular pandemic.
I totally agree. And I think also the efforts to minimize spread have also affected the spread of the other viral illnesses as well. So wearing masks and social distancing and the other things have had, I think, a significant impact. But we've seen very little flu. Matter of fact, I think we've had fewer than 10 hospitalizations for flu this year, which is just unheard of. So, but I also totally agree with the idea that our immune systems, in many ways, especially if you've had COVID, are amped up, and that probably is protected. Almost all of the people who've had flu also had COVID, though. So I don't know what that means. But again, those are small numbers, and it's hard to make anything out of that. But I agree totally with that statement.
Clifton, what about the syringes that can extract 6 doses from the Pfizer vials? Are those available plentifully available, or is that a problem now too, or?
That's not been an issue for us. We've been able to, and actually we're getting 6 or 7 doses out of the Pfizer vaccine. And it's not uncommon when they distribute medications that they put extra in there in case there's issues with drawing it up. So we have been able to get 6 or 7 doses per vial. We are holding the Pfizer vaccine to give the second doses. The Moderna, we are currently just giving it as we give it. I mean, we give it as soon as we get it, without necessarily holding, because we have been able to get second dose vaccines for the Moderna, not so much as with the Pfizer, but when you look at the state of Georgia, I think we've given 920,000 doses of vaccine, of which I read another website that was estimating that 6.5% of the state population has gotten their first dose, which is on par, if not maybe even a little ahead than some of the other states. So again, managing that whole process has been a challenge that unfortunately at the local level, we don't have any control over except to manage what we get effectively and efficiently. So I do think, however, that the idea of giving 1 dose and then waiting and not taking the second dose is not a good idea. I think that it's been tested and shown to work with the 2 doses for at least these 2 vaccines, and we should stick to that. And I think everyone should get the 2 doses instead of delaying the second dose and giving more people the first dose.
Doctor, who decides? Can you hear me?
Yes.
Who decides which people are really critical for the vaccine and those that are not?
The state government, basically the Department of Public Health, has given the guidelines, and the way they implement that is based on the perceived need, and it's fairly consistent, I think, across the country. But again, the healthcare workers and then those who are at higher risk are currently right now 65 and older, and those that some of the other frontline workers such as police and fire and such. The way they're enforcing that is if you don't follow those guidelines, then they're not going to give you more vaccine in the future. And I don't know if you're aware, in Elbert County, they vaccinated several of the teachers, which I think is a great idea, but was not part of their guidelines. And so they've now been told that they're not going to get any more vaccine, which I'm not sure is a real smart thing to implement. But on the other hand, that's how they're doing that. So it's really Department of Public Health, and they're following the lead of the CDC and some other national bodies, but it's largely Department of Health, and then we're complying with and working with them. I will say there's almost a variation on their guidelines on a daily basis, so keeping up with it is difficult, but the head of our pharmacy, Melissa Franks, has been tasked with doing that, and she kept us on target. So we're really at this point still subject to the DPH. I do think once we get hundreds of millions of vaccines available, then that will obviously change significantly, but we still follow exactly what they dictate.
Thank you.
Mm-hmm.
Clifton,
Mhm.
Caroline Armstrong. My sister has had her second shot and had quite a reaction.
Mhm.
And it turns out that a number of people where she lives also had quite a reaction to the second shot. She was okay after 48 hours, but she ran a fever of 102 and was quite sick, and yet she didn't have a reaction from her first shot. Is this unusual? Or, I mean, I've not seen any publicity about the second shot you are more likely to react to.
Yeah, that's actually a good sign if you react to this. So when I got my shot, I had a pretty significant response to my first shot, but I'd had COVID before. So the first shot, if you've not been exposed to COVID, you're just introducing the messenger RNA to the muscle, and your body will then form antibodies. And the immunity to help fight that. When you get your second shot, you now have the ability to respond. And so what you're going to feel are the symptoms like your sister had, or friend had. The symptoms that you're having are the body's immunologic response. It's not from COVID, but COVID causes you to have fever. The reason you have these symptoms is your body responding to the infection. So the fevers and the aches and the chills and everything are just your body's immune response to that. So that's actually a good sign that you have that. I would want you to have it with either the first or second shot, because then I would worry whether or not you had created a immune response to it. But yes, it's expected. I would tell people that when you do have it, take some Tylenol, and it's usually 24, 48 hours, and then you're done with it. But it's fairly profound in the impact that it has. So, but again, think of that as a good thing, because it's showing your body is responding appropriately to the vaccine.
Clifton,
Yes.
have they determined yet, like if you get 2 Moderna, however you pronounce it, shots, could you then get like a third one 2 months out, like Johnson & Johnson?
I don't think so. I don't think, first off, I don't think you need it, but once you get the immune response, there's really no need for a third vaccine or anything, unless they start to show that in the months and years ahead, your immunity starts to wane, and then there may be a role for a booster. But as far as getting a different vaccine, there's really no benefit for that at all.
Okay, let's go.
Clifton,
Uh-huh.
I wanted to ask a question about the variants.
Mhm.
Where is it determined what variants a specific community has?
Red thing.
It's based on the viral PCR testing that's done. We have in the state of Georgia some ability to pick up the variants. The South African variant, I don't think we currently have. One of the big issues that we've had throughout the entire COVID pandemic is the ability to test and test accurately. And so getting the supplies, getting the equipment that's needed to do that. We have the equipment. It's largely just getting the supplies and the solutions that need to be done to do that. It doesn't change how we treat people. So from a treatment perspective, it doesn't really matter. But certainly from a public health perspective and knowing and understanding the variants and how they're spreading and where they're going, it is important. So statewide, they can do some testing at the state level, but most of the testing is being done at the local level. And we currently have some ability to do that. I just don't think we've got the South African yet, but that they've been working trying to get the ability to do that. And I think ultimately that will be all at the local level, but it's done on the same test that they do with the nasal swab for the viral PCR.
And one other question, I know we want everybody to wear one mask, but recently been hearing about the recommendation to wear a double mask. And I just wondered what your thought was about that.
Well, if you're in the hospital and you're taking care of COVID patients, you're going to wear the N95 mask, which is a much more effective filter. Masks are all only as good as what the masks are made of. So you can take one mask and have triple layers, or you can have 3 masks of single layers. The more you have, then probably the better that mask is going to protect others around you from you. And it may provide you some protection from others around you as well. Mostly the mask wearing, though, is not for your own protection. It's really more for protection of others around you in case you're sneezing or coughing and spreading droplets and such. So it all depends on the type mask, whether or not you wear one or not. The ones we wear at the hospital, you only need one. If you're making it out of cloth at home and a homemade mask, then maybe 2 would be better. I'm just happy if you're wearing a mask at all, to be honest with you. At this point, I think as long as you're wearing a mask of some sort, that at least provides some protection. But 2 is probably better, but it's not so much better for you as it is for those around you.
Clifton, what can you tell us about long haulers?
Not much. I'm not really familiar with a lot of that because I really haven't had to deal with it. But there's been some significant long-term effects for some people. And that I don't know the long-term answer to that. It's not that prevalent, but if you're one of the ones that has it, it's a very significant problem. So I would have to defer to other people on that. I just don't know that much about it.
Clifton, Robert Bruner, we certainly appreciate your involvement with the First Methodist Church Task Force. Would you say a word about how that committee functions in terms of recommendations for virtual programming or in-house attendance?
Yes, and I have participated with some of those meetings. Jenny Puckett is actually one of our infectious disease nurse practitioners, and I defer to her because she's probably much better qualified to talk about some of those aspects. And she's on the committee as well. But we started reaching out to churches in mid-December, knowing that Christmas Eve and all the other things coming up were going to be potential large gatherings. And we got very good cooperation from most of the churches throughout the region. And they've done mostly virtual worship. How and when we go from that to more in-person worship, I think all depends on the numbers in the community and the amount of community spread. We are now seeing a significant decline in numbers. And when you look at the ratios of community spread, we are in a much better spot. So I think that there is going to be an opportunity coming forward that we're going to be able to start meeting more in person. But in doing so, you still need to do the mask, you still need to do the hand washing, you still need to do the social distancing. But exactly how and when, I don't know. But the large churches have largely been very cooperative in seeking a lot of resources and input as to how they make that decision. It's largely a committee recommendation, and then I'm assuming that the church leadership is the ones who ultimately makes that decision. But I've been involved with several of the churches in the community and very pleased at how receptive they've been and how supportive they've been, not only in implementing those things, but also supporting the other efforts. And it's been greatly appreciated. But there is a method to that madness. And I do think that now we're going to be seeing some easing of that going forward.
Thank you.
Dr. Hastings? A question. There's been some information on the internet about not taking any pain medicine before you take your vaccination because it'll affect the results. What do you feel about that?
I think for the anti-inflammatories, there's probably some wisdom in not doing that. But I do think once you start having symptoms, it's fine to take particularly Tylenol, because it's not so much an anti-inflammatory. Your non-steroidals such as ibuprofen and Aleve and such are more anti-inflammatory. So for most people, Tylenol would be great. I would not take it before, but if you start to experience symptoms, then go ahead and take it after that.
Thank you.
Clifton,
Yes.
this is Ellen Ewing. I had a question about adult children. I have two sons and a son-in-law, and my son-in-law called me yesterday and said that he had had his annual checkup and found out that he had the antibodies. He had no idea he had ever been sick. He's tested. They have been tested often, and he's never tested positive. My other son, who, along with the rest of his family, all tested positive, and his wife was, let's say, feeling poorly, and but no one ever really got sick, but everyone assumed they had COVID. He went to the doctor within this past week as well, and he had no antibodies. So our antibodies, they are a definite thing, right? If you have antibodies, you've had it. Is that correct?
That's correct. So the antibody testing that they do is specific for this particular novel COVID-19 virus. And so if you have antibodies, your body has been exposed and you've mounted an immunologic response. I think the numbers are over half the people who get COVID are asymptomatic. So we really don't know how many people have had this. But if you don't have antibodies, then you've not had it. And so I think the antibodies in the 90+% range are going to be accurate as to whether you've had it or not. But they also reflect whether or not you've got the ability to respond if you get exposed in the future. And I think largely that's where we're going to see the antibody testing going forward. But it's true. If you've got antibodies, you had it at some point and just didn't know it.
Thank you.
Clifton,
Uh-huh.
it's Latrell. I know probably you as well as Jackie, and certainly I have, that we're frequently asked by people in the community what they can do for physicians and nurses, the whole staff, because of the tremendous burden they're working under. And I just want to make people aware. I know that we're being asked and our hearts are being pulled on for a lot of different things, including this recent horrific issue at the poultry plant. But for anyone that's interested, the Medical Center Foundation, it has a COVID account, and that money is used to do things for the employees and the physicians. They've actually set up a rejuvenation room where staff can go, and meals are provided. There are different benefit things that can benefit them personally as they're struggling through this time. So for those that have asked, or for people that might ask you, I would just wanted you to be aware that there is a very specific COVID account at the Medical Center Foundation, and that's how those funds are being used.
That's totally correct. And I've been sending a lot of people to that to access that, because that truly is probably the most effective way that we can impact the frontline people. The other thing that I kind of neglected to say was one of the things that made the holidays so difficult was not only did the number of cases dramatically go up, but the state support and the number, we're paying a lot of the traveling nursing agencies a lot of money, and we've had tremendous support and help from them. But most of the contracts ended right before Christmas, and most of them did not return and renew their contracts until the middle of January. So we had this great expansion, but suddenly all of the outside support that we had, and rightfully so, they've been working on the road for 8 or 9 months. They all went home for the holidays. And so we had situations where normally per shift, we have 80 or so critical care nurses taking care of all the critical care patients. There were times when we had fewer than 50 available, which meant that they were stretched and taking care of double the number of patients than they normally did. Not a great situation, but you kind of do what you got to do. So the thing that was so incredibly difficult for the staff over Christmas was Christmas. Most of them were working 6 or 7 days a week, taking extra shifts because all the travelers had left. And that particular time was very, very difficult for them on the front lines. Now that we're getting some of the travelers back, they're decreasing the number of days that they work. But that was something that on the outside, you don't know and recognize. But I know those of you on the board are certainly aware of it. It was an incredibly, and we were paying people a lot of money to come and work extra shifts, but physically and emotionally, it was a great toll. So that's one of those little things. And that happens every year for people that use travelers, because the travelers have the option of going home. The people who are still here working didn't have that option. So that was just another small piece that when you learn what you would do different, next time I would try to get travelers and have the extensions across the holidays so that you didn't have that same runoff of personnel and the stress on the staff.
Clifton, hey, it's
Yeah.
Jackie. You and Latrell and I certainly know this, but I think we all tend to we think about the physicians, we think about the nurses, but let's don't forget that there's a lot of behind the scenes folks that are also there day in and day out. The environmental services people who clean those rooms, the food service people who feed those patients, and the staff, and certainly the funeral homes in the area. I have a affinity with Jerry Ward and you know, those people have suffered too. So we just
Absolutely.
don't need to forget about, you know, that this impacts a lot of people in a lot of different ways.
It has. And, you know, I see that in the everybody at the hospital. And again, you know, the people who are repairing the air conditioners and all the other things, we've really had tremendous support from the community in a lot of different ways that helped us get through this. I can remember when they were erecting tents and when some of the heating and air people were coming in and working 24 hours straight trying to get things up and running. So not only is it just the people on the front lines, but there's a tremendous amount of behind the scenes support that this community has really stepped up and done a great job with. So I agree. We need to acknowledge all of those people.
And the people that just stand and wait, that don't go out, that don't go to the restaurants that they want to be in, and don't gather with people from away, need to be reminded that they're helping
They're
too.
doing their part.
Mhm.
We need everybody to do that, because the less spread we have, then the better we're able to take care of this.
Clifton, I have a question about antibodies and the vaccine. A friend of mine had it in June, and she donates plasma regularly now, and her antibodies are still very high. And she was told last week she's supposed to get her vaccine next week, but her antibodies were like 8.9. And she was told not to get the vaccine at this time because her antibodies would negatively affect the vaccine being effective in her body. Is there truth to that, or do we need, if our vaccine is scheduled, do we need to get tested to see if we've had it or have antibodies prior to taking the vaccine?
The current CDC guidelines do not suggest that you do that. They say that it's okay to go ahead and get your vaccine. I will tell you, on your first dose, if you have antibodies, you're going to have the same response that everybody else did when they got their second dose, because you've already been exposed. I think if you did have that information, you could logically say, I'm going to delay my vaccine and let someone else take the vaccine in my place until my antibodies go down. But again, I don't think we've got the ability to do enough widespread testing for the antibodies and be that fine of a delineator of who gets it and who doesn't. And so I think the majority of the time they're just going to say, everybody go ahead and get it. I will say that if you've had the synthetic antibodies or the convalescent plasma, you need to wait at least 3 months since you've had that before you get vaccinated. So it would stand to reason that if your antibody levels are high now, then it would make sense to delay getting the vaccine, but I would at some point get it.
Okay. Thank you.
And that's not an official recommendation. That's just me thinking that.
Clifton, you have been wonderful today, and you've answered so many questions for us and given us, you know, an update. Can you project whatever the new normal is going to be? When do you feel like life might go back to possibly where it was? That's a hard question, I know.
Yeah, I don't know that it's ever going to go completely back, and probably a good thing that it doesn't necessarily. My guess, and again, a lot of this just depends on how much vaccine is going to be available and how much we are able to vaccinate people. But, you know, I don't know, are we going to have a fourth spike? I would just say that if the numbers start to rise again, then we need to prepare for that, because each spike has been bigger than the one before. But I'm very hopeful that with the vaccine that's going to change. If I had to guess, I would say by summer, we're going to have a significant decrease in the number of cases and the number of spread. We're going to have increasing vaccines. And I think that a lot of the restrictions that are being recommended now will be lifted. But I think it's going to be at least another year before life gets back to quote normal for all of us. I think the next holiday season will be much, much different. But I do think, though, that a lot of us have now, through our experiences, will continue to do a lot of the same habits going forward, maybe for the rest of our lives, wearing masks and those kind of things during flu season. I think that's going to be more of an individual thing, but that would be my guess, but it's purely a guess. And I've guessed a lot of things over the past 10 months and been wrong a lot of times too. I thought surely if we just got through April that we'd be okay and we could work our way through this, but that's been far from the reality. But I do think the vaccine is the game changer, and that's what's going to help us get back to where we need to be.
So you agree with the Japanese for wearing masks?
I do right now, especially when you look at the number of flu cases that we've had, or lack of flu cases that we've had. So I think if you're sick, you should stay home. And I think if you have a respiratory issue that you could spread to other people, then we all ought to be wearing masks whenever and forever regarding that.
Well, we thank you so much for your time and for your expertise today. And I know it's been very helpful to us. And come back and join Cross Ties anytime. We're delighted to have you.
Well, thank you. I appreciate it, and appreciate all the questions, and appreciate all the support that all of you have given by following the guidelines and supporting the health system through this time. We couldn't have done it without everybody's help.
Well, we thank you and the health system for carrying us through, and have a good week, and hope that all of our folks stay safe and stay well.
Amen to that.